Hello everyone, welcome to video session 4 for infertility module. So here we are going to talk about very important topic, that is male infertility. How to deal with the scenarios of male infertility in your exam. That is what we are going to talk about today. This is a very favorite topic of RCOG, and many questions do come from this, and probably in this recent exam, the one which was in January, you had around 4 or 5 questions from male infertility. So you can see how much important it is. Okay, so male infertility is a very important topic. So let's start how we have to go about it. So first I'll start with the causes. Causes of male infertility, followed by we'll be talking of how to evaluate what is the cause, and then what are the treatment options we have. So we'll start with causes, then evaluation, and then treatment options. Now about the causes of male infertility. Now, if you remember the complete axis, okay, so on the top, there is hypothalamus and pituitary, which are sending gonadotropins. Gonadotropins are going to act on the testes, producing testosterone, and testosterone leads to formation of all these spermatogenesis and everything going on. So that all process, and finally the sperms have to go to the final destination. So they have to be ejaculated. So overall, the process starts from the brain, then there is testes and final ejaculation, right? So there are three junctions here, okay? So at these 3 steps, there could be defects. So there could be defect at the level of hypothalamus and pituitary. So that will be pre-testicular, before the testes. So that is hypothalamus and pituitary. Then there is defect at the level of testes. Then the causes are testicular. And then finally, there is some problem after the formation of sperms. So there is post-testicular problem. So post-testicular. So we divide the causes into pre-testicular, then there are testicular, and then post-testicular. Now in pre-testicular, that is anything which is related to hypothalamus and pituitary. So what happens in hypothalamus and pituitary, FSH and LH will decrease. Because FSH and LH will decrease, so they will not go and stimulate testes to produce testosterone. So testosterone will also decrease. So there is hypogonadotropic hypogonadism, right? So there is hypogonadotropic hypogonadism, right? So this is happening. Now, because it is not at the level of the testes, it is at the level of hypothalamus and pituitary. Now, there are 2 causes in this. There are certain congenital causes and certain acquired. Now, congenital is when there is deficiency from the birth. Like there is deficiency of GnRH deficiency, where it is Kalaman syndrome. What is Kalaman syndrome? So there is deficiency of GnRH and there is anosmia, loss of smell in the nose. So there is congenital GnRH deficiency and it is Kalaman syndrome. Then there are other genetic disorders that affect multiple organs like Prader-Willi and Lawrence-Moon-Biddle syndromes. Hemochromatosis, in which iron gets deposited in the, there is a defect in the iron metabolism and the iron gets deposited in the pituitary. So that is hemochromatosis. Then there are certain pituitary and hypothalamic tumors, which can be there from the congenital part. So these are congenital causes. Now, what are acquired? Like trauma. Any trauma which may be because of surgery or because of any type of irradiation, vascular causes, infiltrative disorders like sarcoidosis, tuberculosis, they are multi-system disorders. Certain drugs or hormones like increased prolactin, increased testosterone, increased estrogen. When they are increased, the FSH-LH is low. Systematic disorders, chronic illness, malnutrition, morbid obesity. So these are the causes which are basically pre-testicular. That is, they start from the hypothalamus pituitary level. Then these are the causes of the testicular. The problem is at the level of testes. Okay. So here again the testosterone is going to be low. So testicular causes can be again congenital and acquired. Congenital, like Klinefelter syndrome. This is a very, very important syndrome, and this is the most common chromosomal abnormality seen in patients with oligozoospermia, severe oligozoospermia or azoospermia. So we are going to talk about a bit more in the next slides. Cryptorchidism, that is undescended testes. The testes have not reached their final point, so they are lying elsewhere. So if their testes lie elsewhere, then they cannot function properly, because in the scrotum the temperature is lower, and that is required for proper spermatogenesis. If testes are somewhere else, then they cannot work. So within 1 year of the birth with orchidopexies, the testes have to be brought to their normal location, else they will be destroyed. Y chromosome deletions, these are genetic disorders, again a very important component. We are just going to talk about in a bit more detail. Defective androgen synthesis, or there is a problem with response, that is androgen insensitivity syndrome. Now there is acquired causes like varicocele, any type of infection, particularly like mumps, any drugs, like cyclophosphamide, they can damage the testes, environmental toxins, smoking, hyperthermia. I just now told you that testes lie in the scrotum, so they need lower temperatures to work. So if there is hyperthermia, long heat exposure, then it is a problem, and then there could be anti-sperm antibodies. So testes may be damaged because of congenital causes or maybe acquired causes. Now we talk about post-testicular problems. So here the problem may be congenital, that is sperm transport problems are there. So sperm are non-motile or something like that. So basically there is a transportation problem, and or which can be present at the level of epididymis, at the level of vas deferens, seminal vesicles and prostate, or finally there could be defective ejaculation. Now at the level of vas deferens, the bilateral absence of vas, congenital bilateral absence of vas deferens, CBAVD. This is a feature of cystic fibrosis. So if any such picture is there, we have to look for cystic fibrosis gene mutation. Defective ejaculation, example is either there is a erectile dysfunction, which because of that patient is not able to ejaculate at a proper time, so that has to be treated, or there can be retrograde ejaculation. So instead of semen being released outside, it is going and mixing in the urine. So these are the two most common defective ejaculation problems. So reaching a final diagnosis, what is the basic problem that has to be defined to find a proper management option for these patients. Now let's see a few things about Y chromosome microdeletions. This is important, particularly if there is a azoospermia or very, very severe oligozoospermia, like counts less than 2 million. Okay. So there you have to check about these microdeletions, because what happens in these cases, in severe oligozoospermia or azoospermia, you do ICSI. You take out sperms from the testes and then you do ICSI. But if the patient has any such genetic problem like Klinefelters or Y microsome deletions, then it is liable to be transmitted to the offspring also. So therefore, in these severe problems, it is very important that you rule out genetic conditions first, so that whatever sperm you are giving to the offspring, that should be a healthy sperm. Okay. So Y chromosome microdeletions should be looked into in those cases where there is oligozoospermia, severe oligozoospermia, or there is azoospermia. So AZF region is there on Y chromosome, and it has three types, A, B, and C. And these regions are required for normal spermatogenesis. So AZF region with A, B, C, that is required for normal spermatogenesis. Now, if there is a deletion of C segment, which is most common, followed by there is deletion of B segment, followed by there is deletion of B and C or A, B, C. But the A deletion is very, very rare. Now, men with these deletions are generally azoospermic, particularly A and B. AZFA and AZFB region deletions, they have azoospermia. Even if you go into the testes and try to look for sperm retrieval, it is not possible because there are more chances of azoospermia. So they are unlikely to benefit from testicular sperm extraction. So it is important to do this test once to see that if there is anything which can be transmitted to offspring. And second is you will also come to know the prognosis, or you can pick up a proper technique which can work for you. Now, men with deletions of FC region, which are majority, they have a variable phenotype. And in this case, in 50% of cases, you can pick up sperms from the testes. So sperm retrieval from the testes is possible in these patients. Klinefelter syndrome. Klinefelter syndrome is the most common sex chromosome abnormality. Adult men with Klinefelter syndrome have small, firm testicles devoid of germ cells. So there is again azoospermia. Leydig cell function is commonly impaired in these men, and testosterone levels may be normal or low, estradiol levels normal or may be elevated, and FSH levels are increased. Now, because the testosterone is low, the problem is at the level of testes. So testosterone level is low. So the low testosterone, no feedback on the FSH and LH. So it is going to produce FSH and LH. So all the picture of testicular failure is coming here. So an extra X chromosome is the most frequent reason, and germ cell presence and sperm production are variable in men with mosaics. In mosaics, there can be variable amount of sperms can be there in the testes. Now, when we talk about evaluating, we just talked about the causes and then how to evaluate. So, normal semen analysis, we have read in our previous video of investigations, what are the features of the normal semen analysis. Okay, so we have to follow that WHO classification. Now, if any of these features is abnormal, then abnormal semen analysis. How to deal with this? Although we have talked about this interpretation in investigation video, but I'm talking about it again here to complete a picture. So here, abnormal semen analysis, repeat after 3 months. If there is a abnormal semen analysis, repeat semen analysis after 3 months. While if there is a gross spermatozoa deficiency, there is azoospermia or there is severe oligozoospermia, then repeat it as soon as possible. Okay, but it is important that you do 2 tests, then you make a diagnosis. Don't make a diagnosis by a single test. So if your question has given only 1 semen analysis, you have to order for the second semen analysis, and the time period will depend on here this cutoff. If usually it is 3 months, but if it is a case of gross spermatozoa deficiency, that is azoospermia or severe oligozoospermia, then you will do it as soon as possible. But remember, 2 tests are must. Now, this is a very, very important chart. This is very, very important chart. Of course, the red dot you see here on the slide itself shows that this is a very, very important chart. So in this case, you have to look at hormones, FSH and testosterone, and accordingly, we have to make diagnosis. Now, if the problem is post-testicular, so that means the path is defective. The FSH-LH is normal, testosterone is normal, but finally the sperms are getting produced, testosterone is also getting formed because testes is functioning normally. But there is some obstruction so that the semen is not going out. So there is normal FSH, normal testosterone, and there is obstructive or post-testicular defect. Then there is primary hypogonadism. Now, primary hypogonadism means gonads are not functioning properly. So primary testicular cause. So now because gonads are not functioning properly, so testosterone is going to be low. Testosterone is low, no feedback to pituitary. So it will keep on producing more of gonadotropins. It will keep on producing. So FSH is high. Now, this is secondary hypogonadism, that is pre-testicular. Hypogonadism is there. Testosterone is low, but it is not because of testosterone cause. It is not because of cause at the level of testes. It is because of the cause at the level of hypothalamus and pituitary. So this is hypogonadism is there, but that is secondary, not from the primary level of the testes. So this is secondary hypogonadism and this is pre-testicular, right? It starts before the testes. So in this, FSH and LH is not produced in adequate quantity. So that is low. And now that is low level of FSH and LH cannot stimulate testes to produce testosterone. So your testosterone is also low. So this is secondary hypogonadism and pre-testicular. Now, this is the scenario of anabolic steroid abuse. Very, very, very favorite scenario of RCOG. Very often you see these questions. When you go to part 3, you also see these cases also in discussion about the anabolic steroid taking male. Okay. So they will give you some example, like some scenario of a gym freak who builds a six-pack and he is taking steroids to build his body. Something they will build like this scenario. So there is anabolic steroid abuse. So what is happening is he is taking steroids, which is causing excess production of testosterone. So testosterone is being produced. Now that testosterone is basically from the outside source. Okay. So the outside source testosterone is giving a feedback to the pituitary to produce less of gonadotropins. Okay, because high level of testosterone is there, so it is giving pituitary that you produce less amount of FSH. So that is producing less amount of FSH. So low FSH. Now low FSH, it will not. No adequate stimulation to testes will be there to produce the testosterone. So the testosterone which is produced from the testes will be low. But overall, there is high androgen in the blood because of the outside source of androgen you are receiving. Okay. So FSH is low, but your testosterone is high. Now, looking at these two values, you can see to which category you belong. Now, why it is important to look at this category, right? Now, look at these options. Obstructive. So, there is a post-testicular defect, right? So, if there is any obstruction which can be corrected, then you can correct it, open up the vas, and semen will go up. If there is a ejaculation problem, you will work accordingly for this. If it is non-obstructive like of azoospermia, that is there is a functional defect, then you can pick up sperms from the testes and do the ICSI. So in post-testicular, depending on what is the cause, you can deal with it. Of course, I'm going to talk in detail about the treatment options, but to give you idea why this dividing the patients into these categories is important, because accordingly we will formulate the treatment. Now, if you look at primary hypogonadism, there is a problem in testes itself. Testes is not producing enough testosterone. There is a high stimulation from the gonadotropin, still testes is not producing. So it is like a burnt horse. No matter how much you force it to do, it cannot work. So nothing, you can't have any gonadotropins or anything can't be put to work here. Testes is failing. It does not have enough capacity. So you need outside sperms, donor sperms from that. So this is a case of testicular failure. Now, secondary hypogonadism, this is a level of gonadotropins. So here, if you give gonadotropins, they are going to work. So you are fulfilling the deficiency of gonadotropins. You give gonadotropins that will stimulate the testosterone. testes to produce testosterone, and testis will start making sperms. So secondary hypogonadism, that is pre-testicular, you can use gonadotropins. Now in the last scenario of anabolic steroid, you have to stop whatever extra drug that or extra powder or whatever preparation that person is taking, he has to stop that. So he will stop that. You repeat a test again. And since the cycle of spermatogenesis is 3 months, so you have to wait for at least 6 months to see the reversal. So to see the body producing its own normal testosterone and enough sperms being produced. So for anabolic steroid abuse, good thing is just stop whatever the extra thing he is taking, stop that, and body will then start its own cycle. Okay, so therefore looking at these values in exam is a very important thing. Accordingly, you see what is the scenario and answer your question. So this way it is very, very easy to answer questions of male infertility. Now, what are the important rules? So if in post-obstructive, I said in post-testicular, these things will be normal. So FSH, LH and testosterone are normal, and man has absent or low volume semen at ejaculation. And there is severe oligospermia or oezospermia. So it could be simple thing that there could be retrograde ejaculation. So you take a post-ejaculatory urine sample. What is happening in retrograde ejaculation? Instead, the semen is being expelled. It is going back into urine. It is going and mixing in the urine. So you take the urine sample. Post-ejaculation urine sample you take, you will find sperms in it. So in these cases, it is good to look for this. If it is a case of hyperprolactinemia, then it should be measured in men. Prolactin should be measured in men who complain of reduced libido. Reduced libido is a keyword for scenario of hyperprolactinemia. Okay. If your question says reduced libido in male infertility, they are looking for an answer related to prolactin levels. Okay. So reduced libido is a keyword for prolactin, and these patients also show low serum testosterone. Low serum inhibin B may be more sensitive indicator of primary testicular dysfunction than high FSH. Now, this is a chart which will answer all your questions in exam. Okay. So what are the treatment options? Now, I have already explained you. So I'll just summarize or give you a clear viewpoint how you have to answer. So now if it is a hypogonadotropic hypogonadism, what is this category? This is pre-testicular. The problem is at the level of pituitary and hypothalamus. So you have to give gonadotropins. Then next thing is the hyperprolactinemia. Hyperprolactinemia, higher prolactin levels. So there can be some offending medication which you can stop, or you can start dopamine agonists like bromocriptine or cabergoline. And now after you start, wait for 6 months. Within 6 months, these all things should revert and testosterone should come to normal level. But if it does not come to normal level, then you can add HCG or GnRH. Now, if you look at this type of scenario, then you can find a testosterone estradiol ratio. If this is not getting solved, then you can look at testosterone estradiol ratio. If it is less than 10, that is, estradiol is 10 times higher, which should not be there in males. So in that case, you need to use or add some anti-estrogen drugs. Now, obstructive azoospermia, that is, there is azoospermia, but levels are normal. Testes is normal, FSH is normal, testosterone is normal. So what you can do, either you can open up the obstruction if possible, like in vasectomy. In vasectomy, you can do a reanastomosis, so surgical correction can be done, or otherwise in all other cases, instead of working on the vas, it is good to take a sperm retrieval, directly retrieve the sperm from the testes and use it for the ICSI or the IVF. Not ICSI always, it can be just simple IVF. Okay, so just take the sperm from the testes and do the ART procedure, and that's all, right? So sperm retrieval and IVF or surgical correction. Surgical correction is usually an answer only when we talk about vasectomy reversal. Okay, otherwise in all other obstructive causes, for exam point of view, you will choose always sperm retrieval and ART, right? So this is one which you are going to choose. If there is a question about vasectomy reversible, then surgical reanastomosis is the right answer. Retrograde ejaculation. In this case, semen is going and getting mixed in the urine. So you said when you take a post-ejaculatory urine sample, it has sperms. So you will have to take out sperms from that. And then you can take out those sperms and do IUI with that. So basically, collect the male partner spermatozoa after alkalinization of the urine and wash sperms. Sperm washing is to be done. And then what sperms you have, you can use it for the IUI. So this is how you can answer your questions. Now, what are the various other techniques which are used, like IUI? What is role of IUI and what is role of ART procedures? So let's look at this intrauterine insemination. Now, this is usually not done in male infertility scenarios. No, male infertility scenario is never an answer is intrauterine insemination. Okay, it is only an answer in these three conditions: when men who are unable to have intercourse, or there are same-sex couples, or men with special conditions like HIV, where you need to do sperm washing if the criteria of allowing for normal intercourse are not fulfilled. That is, patient is not on heart or the viral count is high. So then in that case, you need the sperm washing. So intrauterine insemination is never an answer when your semen analysis is not good. Okay. It is an answer when men who are not able to have intercourse, same-sex couples, and men with special conditions like HIV. So don't do IUI. Means don't tick mark this answer in your exam. If you are dealing with a scenario of unexplained infertility, if you are dealing with a scenario of mild male factor infertility or mild endometriosis, never choose IUI. It is directly IVF which has to be done. Now, what about the ART treatments? So, sperm retrieval with ART is an alternative to microsurgical repair for men and correctable reproductive tract obstruction. So, instead of obstruction correction, it is good that you take the sperms from the testes and do the ART. Okay, but remember, whenever there is a problem, particularly with the non-obstructive azoospermia, always try to look for the genetic testing of female partner is essential, where the male partner has bilateral vasal agenesis. Congenital bilateral absence of vas deferens very well goes with the cystic fibrosis. And cystic fibrosis is a autosomal recessive disease. Autosomal recessive disorder matlab means both the partners. The defective genes should come from both the partners. Then offspring will have that disease. So therefore, female partner should also be tested for CAFTR gene. Now, what is the role of ICSI? ICSI is intracytoplasmic sperm injection. What is difference between IVF and ICSI? In IVF, you do the fertilization takes place in vitro, that is outside the body. You take the ovum, you take the sperm, and you create an embryo in vitro. But you allow them to to fertilize, you allow the sperm to fertilize naturally. You just bring them together and then fertilize, then the sperm fertilizes the ovum in a natural way. But in ICSI, you take one sperm and you put it into the ovum. Okay, you don't allow them natural mating, you just put that sperm into the ovum. Now that means the sperms, there was some type of failure in the IVF, or sperms are not, doesn't seem to be that adequate amount or adequate quality, so that IVF is, you think, is not possible. So ICSI is basically done when there are severe defects in semen quality. When there is obstructive azoospermia, you can get only less number of sperms from the testes, or in cases of non-obstructive azoospermia. So you collect whatever sperms are available to you, you pick up a very good sperm and inject it directly into the ovum cytoplasm. So remember, only in these three conditions, because they give you two options. They also give you IVF and they give you ICSI also. So people get confused whether to choose IVF or ICSI. So choose ICSI, because ICSI itself includes IVF. ICSI cannot be possible from a, like you take a direct sample from a patient sperm and you inject that sperm into the female body. No, you are already taking the ovum out. So when you are taking the ovum out, you have already done all the steps of IVF in female. So when you say ICSI, it already includes IVF. So for these 3 points, if your question has option of IVF and ICSI also, choose ICSI. Okay. So severe defects in semen quality, obstructive azoospermia and non-obstructive azoospermia. This red mark shows this is a very, very important slide. And mind you, 99% you will have a question of male infertility in which answer will be ICSI. Okay, so don't tick mark IVF in that. Severe defects in semen quality, obstructive azoospermia and non-obstructive azoospermia, choose ICSI. Now, what is important in ICSI is that, because you see that there is a severe oligozoospermia or azoospermia. So rule out genetic defects. That is what I talked of in Y deletions and Klinefelter syndrome. Because if there are severe defects, then there is a possibility that the genetic abnormality is there. So you don't want to transmit that. So therefore, that should be ruled out. Now, these are the techniques of sperm retrieval. So either you do sperm retrieval from the epididymis, or you do a sperm retrieval from the testes directly. So this is MESA and this is PISA. So this is micro epididymal sperm assay. So in the aspiration. So in this, what you do is you give a small incision and then you take out the aspirate. While this is percutaneous. So it is through the skin. You just insert a needle through the skin and you aspirate it with the syringe. While in this MESA, you are actually giving a small incision and then you take out the aspirate. So because here you are directly entering inside, so in MESA, chances of sperm retrieval are more as compared to PISA. PISA is percutaneously, you are just aspirating the liquid. So this is MESA and PISA when you are working on the epididymis. Now there are techniques for testicular sperm retrieval also. So same, it is percutaneous like you had PISA. Here you has percutaneous, or it is also known as testicular sperm aspiration, because you are just aspirating it. You don't give any incision on the skin. You just inject the syringe and take a needle and take out aspirate. So this is TSA, okay, testicular sperm aspiration, or there is percutaneous. Then there is incisional. You give an incision and you take out some seminiferous tubules, big, good-looking seminiferous tubules, healthy-looking seminiferous tubules, and then you take out the sperms from that. And then there is microsurgical, in which small incisions are made, and this is microsurgical assisted. So this is how we have different types of the of taking out procedures of the sperm retrieval. Of course, the microsurgical one gives the best results, and that leads to maximum sperm availability. Now that was about the ICSI and the sperm retrieval. Okay. Now, what about the donor insemination? When you need donor sperms. Okay. So of course, if there is a scenario of testicular failure, testis is not at all producing any sperm. So there is azoospermia. Okay. There is azoospermia in which even your testicular biopsy does not show any sperm. See, testicular biopsy is a very important component, because if you are planning to take the sperm from the testes directly, first you have to take biopsy and see how is the tissue of the testes, what type of spermatogenesis is happening there. So you have to look at it. So finally, when you see that, you have to take the sperms directly from the testes. So you take a testicular biopsy and define accordingly whether the testes have sperms or not. If testes have sperm, then you can do the sperm retrieval and ART. But if testes does not have any sperms, then what you have to do? You have to take a donor semen. So again, obstructive and non-obstructive azoospermia decided by testicular biopsy, whether you can do sperm retrieval or you can do donor insemination. So how will you choose an exam? If the testosterone levels are normal, right? If testosterone levels are normal, there are some sperms, then you will choose the sperm retrieval. But if they clearly give you a scenario of testicular failure, that is, the testosterone is low, FSH is going very high, then you will have to say that this is a case of testicular failure and you will opt for donor insemination. This is how you can choose in two different scenarios. Single parent, of course, she needs a donor semen. Same-sex couples, they also need a donor semen when there is a high risk of transmitting genetic disorder to offspring. So I already told you that if there is a high risk, if you are planning ICSI, you tested semen and there was a genetic disorder, then you cannot use that sperm. So you will have to take a donor sperm. And severe rhesus isoimmunization. So now when you take these donor sperms, you do IUI. Why you need IVF? IVF may be needed for any female factor, but not for male factor. So in donor insemination, it is donor IUI, right? So donor semen, IUI. So single parent, same-sex couples, testicular failure patients in which sperms cannot be retrieved from the testes, and when there is a high risk of transmitting genetic disorder and severe rhesus isoimmunization. So in these, you will choose the donor insemination. So now we have seen when to choose donor insemination, when to choose simple IVF. Whenever you are taking sperm retrieval, you can do IVF if it is not case of severe oligozoospermia. But if it is a case of severe defect, you will choose ICSI. Right? So up till this, it should be fine. Now, what are the rules for assessment of female partner in donor insemination? How will you assess that female partner is okay for donor insemination? So you have to confirm that woman is ovulating. How do you confirm that woman is ovulating? By looking at mid-luteal phase progesterone. If there is a history of comorbidity leading to tubal damage, then you will offer her tubal assessment. Okay. But if it is not so, then there are no risk factors which shows that there is a problem with tubes, then you can even go for 3 cycles without doing the tubal test. Okay. The female is ovulating, semen you have from the donor, so you can just do the IUI for 3 cycles without evaluating the tubes. Okay. But if there is any history which suggests that there is a tubal problem, then in that case, you have to do the tubal test. 6 months, you can do 6 months IUI if the woman is ovulating regularly before taking any other decision. So you can give her a trial for 6 months. Waiving of donor anonymity, we discussed the same thing when we talked in the video of legal issues. So from April 2005, children conceived using donor sperm are able to trace their biological parents and siblings in the same way as children who are adopted. So basically, they will come to know about from where the sperm came. So they will come to know about their biological father. So because of this donor anonymity, which they have waived off, now the donors for the semen are less. What treatments are not to be done? So men with leukocytes in their semen should not be offered antibiotic treatment unless there is a specific identifiable infection. Then there is anti-sperm antibodies. So anti-sperm antibodies are usually, they are important if they are 50% of the sperm are bound to sperm antibodies. But routine screening from anti-sperm antibodies is not offered. If there is a case like this, then ICSI is the treatment of choice for these patients. Varicocele, very favorite scenario. So varicoceles, what are these? They are dilatations of the pampiniform plexus of spermatic veins in scrotum. It occurs next to and above one or both of the testes, and approximately it affects 1 in 7 men. So there is dilatation of the veins. There is staging also, 1, 2, 3. One is, it is visible only while standing. Second is, it is palpable only on standing. Second is, it is visible on standing. And third is, it is always visible. So there is a staging pattern. No need to go into this much details, but it is important to understand left-sided varicoceles are more common, because here the testicular vein directly goes into the renal vein at a 90-degree angle. So because of that pressure effect, there is left-sided varicoceles are more common. They are found in 11.7% of adult men. But if you look at a men who have abnormal semen analysis, then incidence increases to 25.4%. So that means there is some correlation between these things. So men should not be offered surgery for varicoceles as a form of fertility treatment because it does not improve pregnancy rates. This is as per our NICE infertility guidelines. What the strategy says? It says that, of course, varicoceles cannot improve the pregnancy rates, but a consideration can be given for the varicocele repair in men with non-obstructive azoospermia. Because some studies have shown that the semen parameters improve if varicocele is repaired. So now, how to decide in exam what to answer? So mostly in questions of varicoceles, no surgery to be offered. But if they have specifically given you, they are highlighting that they are giving you a scenario of non-obstructive azoospermia, then, and they say that you can consider varicocele, then you can choose the surgery for that. Now, this is from the TOG article of male infertility, which was in recently published TOG article. So the important points are, while you are doing ART, how to do a sperm selection. So live birth rate in ICSI remains static at 25 to 30% per fresh treatment cycle. Sperm DNA integrity is key in determining its competence, because finally, what is the function of sperm? Sperm is just giving its DNA to the ovum. That is the only function of sperm. So if the DNA is defective, it is not going to work. So sperm DNA integrity is key in determining its competence. Now, tests to evaluate DNA fragmentation. There are multiple tests, but none of them is recommended as per evidence. So the names of tests are sperm chromatin structure assay, SCSA, sperm chromatin dispersion test, terminal deoxynucleotide transferase mediated deoxyuridine triphosphate Nick and labeling. Short form you can remember as tunnel, and single cell gel electrophoresis COMET assay. Just mentioned these names because very fancy names. Sometimes you may have any SBA about it, so just mention them, but they are not very much recommended. There are a few newer developments which are mentioned in the talk. So this is microscopic evaluation of the sperms. So selection of MSOM, this is selection of morphologically evaluation involves real-time, high-powered observation of unstained sperms. And then you do the IMSI. What is IMSI? You do the injection of morphologically normal sperm. The one sperm which you see that it is a morphologically, 6 parameters are there. You look for various organelles, like you look for acrosome, you look at nucleus, you look at mitochondria, you look at exonemes, tail. So 6 features are being tested, and accordingly you calculate you do the morphological evaluation. The best one you choose is injected directly as you do the ICSI, but it is with the morphologically evaluated sperm. Another test is hyposmotic swelling test, in which you put the sperms in a solution of hypoosmotic solution. Okay, so what happens? The sperm, if their plasma membrane is good enough and it is working properly, it will absorb all the fluid from the outside. Now, as it absorbs the fluid, it swells up. Okay, but this is a reversible. As you take out the sperm out, it will the water will go out. So with this, you can test the sperm is viable. Okay, because if it is viable, if its plasma membrane is proper, then only it will swell. So you can pick up the viable sperm, and then because it is reversible, so your sperm will again become normal and you can use that sperm for the ICSI. Then there is a PICSI, which means that physiological ICSI, in which you select a mature sperm which is bound to the hyaluronan microdots. Why? Because for the oocyte, there is a hyaluronic acid which has to be bypassed by the sperm. So those sperms which can actively bind to the hyaluron microdots, they can penetrate the oocyte well. So in this case, you label these sperms with the hyaluron microdots, and then they go and pierce the oocyte. So this is physiological ICSI. You are facilitating the sperm to go inside the oocyte cytoplasm. So this is physiological ICSI. You are trying to mimic the physiological environment. So this is all about the male infertility scenarios. Very, very important. All those which are marked by the red sign are important slides. So if you just read this much about the male infertility, I hope you can answer all your questions in exam. All the best. If you can dream it, you can do it. So just keep working with MRCOG courses and you will be able to do it. So that's about today's session. Your feedbacks and your queries are welcome. And of course, thank you for joining today. And thank you. Thank you so much.